The UK has more than 200 NHS trusts, and up until recently, the way services were bought and chosen was through 211 clinical commission groups, and now that's been changed and consolidated to 42 integrated care systems. And even when we're talking about the One London project, it's actually one of quite a few local healthcare record exemplars. There's other cities that are doing similar things: Manchester, Yorkshire and Humber, Wessex, Thames Valley and Surrey. So when talking about collaboration, I really wonder, do you guys talk to each other and share experiences? How each of these huge projects covering millions of patients is progressing? What are the similarities, differences, where you could potentially help each other?
Yeah, we do talk actually. When the Leica program was established, there was a wonderful couple of leaders really who established it at the start. So Indy Singh and John Farringham, and they always brought us together to make sure that we were sharing. And within that community, we've all tried to baseline on the IHE standards predominantly. So as a technical person, we like to make sure that they talk, and we have managed through One London to connect beyond London. So we've got interim connections into Milton Keynes to enable the flow of patients north of London. We speak regularly to the east of England, so when they're ready, we'll be able to support the connectivity of patient records out of London to the east of England as well. So we do talk, and in the technical community, which is predominantly where I operate, there's a lot of collaboration and a lot of support for each other to help us join the records up. Because I think nationally we've been in a bit of a transition period for quite some time following the national programme for IT, and almost feels like there's a slight reluctance to define a national architecture at times, just because of the potential political ramifications that might come from that. But I think we do need, my personal view, and this is a personal view, we do need to start rethinking what national architectures look like in England, because there's some significant gaps and some quite difficult levels of complexity to overcome when you try and do everything locally. So I think there's a good balance to be found when it comes to the implementation of these kind of systems. And when I say system in that context, I mean health system, not IT.
Mm-hmm. Earlier you mentioned the complexity of achieving interoperability when you've got hospitals that already use several systems that are not necessarily integrated, and then you have to do some sort of a wide-scale integration on a regional level. And I guess anytime any of these large-scale projects start, a similar story could be the health data space. You know, you as the initiator of these ideas, you have to stop a little bit and think, based on all the problems that we know about data standards and interoperability, how can we go forward in a different way, in a better way? So can you maybe talk a little bit more about the thinking behind the technical architecture and infrastructure for One London, if you know what I mean?
Well, I mean, I'd love to say there was like huge amounts of thinking that went into the platform itself. London's architecture is based on the Cerner platform predominantly. So we've ended up in a position, because 80% of London is Cerner based when it comes to the acute organisations, we've got a bit of a mesh architecture now. So we've got a hub health information exchange that sits in the middle, and then around that we've got 5 integrated care system spokes, if you like, that then connect in and allow sharing across each of the others. And then the hub is really what we then use to stretch out beyond London into Milton Keynes and the east of England, as I described a moment ago. The health information exchange provides us with standards-based interoperability when it comes to consuming and publishing information, and is available at the point of care through a portal, effectively. So in your clinical system, you click a button. We have the NHS number in England, which is an amazing invention which means every individual is identifiable by the same unique identifier, which helps us massively when it comes to contextualizing the record in existing systems. And through that contextualization allows us to launch a portal and then pull the information using the NHS number from every other connected information exchange that are within the network, and then present that to the clinician at the point of care. And then moving beyond that, in the last year, because Cerner has some limitations, we've had to purchase a care planning or a record, if you like. It's a form building and workflow system by a company called Better Health, which they have overlaid on top of the London Care Record, which again is just the portal. But that then gives us the ability to capture information such as care plans. So we're using it for end of life care planning at the moment, but that will then go beyond that. So we hope to use it for mental health, so for paediatric intensive care management, and some other end of life type hospice referral pathways. So it's quite complex in the sense that there's a lot of data going in from primary care, secondary care. We've got a lot of APIs that we call from third-party systems to bring the data into the portal. But it's really seamless to the consumer. They just click a button. We look at their role based on who they are. We give them the right level of privilege and access, and then they see the information at the point of care.
So basically they have the experience that they would expect to have if they knew nothing about IT.
Yeah, we try and make it as easy as possible. I'd still say that there's some work. Just to be completely transparent, there's areas that we can improve. The user experience, I think, this comes back to what I was saying earlier about we've not really evolved since when I started when it comes to user experience. I think there's some good examples of good user experience starting to come into the healthcare industry, but the systems that we're using, they don't come from and haven't been designed from a user experience based design, user-centered design background. So they are very much, I feel like, built by developers for clinicians with a developer's understanding of user experience and user-centered design. So they're very information rich, which makes them very difficult to use at times. So one of the things we've got to do with the London Care Record is try and improve that over the next 12 to 18 months as well.